very close friend, Dr. Harshul Tak, who is a master of doing cataract surgeries, especially in difficult, challenging situations, is the best person to talk to us about how to perform cataract and get optimal outcomes in presence of ocular trauma. So, over to you, Dr. Harshul.
Thank you very much, Dr. Vardhaman, for including me in your course. So I'll be taking you through 3 or 4 traumatic cataract cases, different scenarios. We all know that uh, penetrating or ocular or blunt ocular trauma can lead to traumatic cataracts, and it can present in varied form. So this is the case, a young female, 28 years old, who had this thorn injury. You can see here on cornea, there is a penetrating injury which occurred, and within 2 days she developed the cataract like this. So whenever we have a case where the anterior capsule gets ruptured, so we know that the cataract, it forms very fast, so we need to take care of this cataract. But we know that anterior capsule is ruptured, so we always have to counsel the patient about that the PC may be ruptured. We may have to do posterior segment intervention. We may have all the options have to be discussed with the patient. That is very crucial in scenario like this, because once we go in, once we take out this fluffy cortical matter, then only we come to know that what is the status of the posterior capsule and whether vitreous is there or not mixed with this cortical matter. So let's see how the case proceeds. So it's important that once I make side port incisions, you need to be very careful that you don't damage further. So just make side port incisions, and after making this, I see this fluffy material, so and this is under just topical anesthesia which I am doing, and here I'm just putting some saline there so that the extra fluffy material which is there, it gets washed off and comes out, and I can see the capsule clearly. And after that, I'd like to stain anterior capsule, which is very important, so that you can map out that what is the extent of the tear which is there. So all this fluffy material, it's coming off once you stain, and after that I go ahead and put viscoelastic. But remember that don't put much of the trypan blue, because it may, if there is a zonular dialysis, it may percolate behind and may cause issues with the visibility. So here I'm just making this main port incisions, and I can see that my anterior capsule is torn here like this. So you have a split there in the anterior capsule. And another principle which you have to remember is that always try to maintain closed chamber, because these are the fluctuation of the anterior chamber which may cause vitreous disturbance if it's not disturbed. So slowly I go ahead and put irrigation cannula and try to take off this fluffy cortical matter. So I've not done anything here, trying to make any capsular access, because I can see this split here, and I'm just releasing this synechia which is there. So you need to be gentle, you need to be meticulous. So just take off the cortical matter, going from different port. So you need to go very slow. And here, this is my viscoelastic cannula. So you can see, I just go ahead and put some visco beneath the anterior capsule and the entire fluffy material. So this is visco expression which you can always do, and because of the curve of this, continuous curve of this cannula, you can reach till the equator also. So I take off this fluffy material, again going with viscoelastic cannula, putting. So I'm maintaining closed chamber and try to take off the fluffy material. So again, visco expressing the cortical matter. So in the end, I have, as you can see, on one side I've taken off the entire cortical matter, and again change my hands, and so you can see a very big split there in anterior capsule, but posterior capsule is intact, and there is no wraparound tear at this stage. So we always have to, that's the importance of maintaining closed chamber at every point of time. So once you clear off the entire cortical matter, I'm just seeing the extent of the tear on both the sides using Kuegelin's hook. So I can see that it's limited till equator. So in scenario like this, you can easily go ahead and put a single piece IOL encapsular bag with the haptics perpendicular to the where the capsular axis is torn. So I go ahead and I'm not rotating the nucleus, the lens here. I'm just bending the haptic and pushing it in the capsular bag so that you don't have those rotational forces. So once you have IOL in capsular bag, you can see you can go ahead and use micro scissors to cut on both the sides and try to just enlarge the rhexis. I go on other side also and just make capsular axis of adequate size. So again, in the end, take off all OVD and just maintain closed chamber, put irrigation cannula inside, and you can hydro stitch your incisions, and this finishes the case. This is another case which had trauma, blunt trauma, and presented, I think, 2 to 3 months after trauma. And you can see that because of this blunt trauma, the patient had subluxation. So it's very important that you dilate pupil nicely and see that how much is the extent of subluxation here. The subluxation was more than 5 to 6 clock hour, and also there was fibrotic anterior capsule. So whenever you are dealing with the capsule like this, fibrotic capsule, it's really difficult to make capsular axis. So remember, through fibrotic area you need to cut with micro scissors, so you need to go through different ports. So when I reach in the area of non-fibrosis, I try to fashion capsular axis using forceps. And after that, once you reach in the area of fibrosis, you may need to use bimanual technique. Keep holding flap with one hand and go with left hand, and so you need to go through various angles, and if needed, 1 or 2 extra side ports are also essential to go through correct angle. Once you reach in the area of subluxation, remember we need to put capsular hooks here, so you need good tissue rim of 2 millimeter of anterior capsule here. So cut through this area. So here I have a good capsular axis. Go and put some viscoat there to tamponade anterior vitreous phase. And depending on area of subluxation, you may need to use 2 or 3 capsular hooks depending on area of subluxation. So here I go ahead and put 3 capsular hooks in the area of subluxation. This is important to support the capsular bag in the anterior posterior direction. And most of these traumatic cataracts, we know these are brittle, they are softer ones. So nothing great in chopping this nucleus, but still you need to again maintain closed chamber. That is very crucial, that you don't let antechamber collapse at any point of time. So once I take off the nucleus, I go ahead and put viscoelastic. And now the job of these capsular hooks is over, but you need CTR ring here to centralize the capsular bag to give it equatorial support. So I go ahead and put this CTR ring. If you are comfortable, you can use Sioni CTR, because in the end you need to fixate this capsular bag. So you just use Kuegelin's hook inside and put CTR. So once the CTR is placed, you have capsular bag nicely stretched. You take off all cortical matter nicely. And now is the time to put capsular tension segment, so that for long-term stability we need to anchor this capsular bag to sclera. So this is a 90 proline which I am using. Now I started flanging these CTS segment using 50 proline suture, but this was before I was using 90 proline. So you pass this double arm suture through eyelet, put this segment in capsular bag and railroad both the ends either through Hoffman pocket, or this is the 1.5 millimeter behind the sclera. I made the scleral groove. So once you railroad both the ends of the proline suture, you just titrate the tension and tie a knot there and bury this knot in scleral groove. So now you have this segment fixed nicely to the scleral wall, and which gives us long-term stability. And this was a traumatic cataract, so I decided to go ahead and put a single piece IOL in capsular bag. If it's a progressive zonulopathy, you may choose to put a 3-piece IOL. So here again, IOL goes nicely in capsular bag, and this finishes the case. And I think one last case I'll just like to show quickly in few seconds. So many times you may have a traumatic cataract along with some iris defect. The traumatic mydriasis is there. So you may need to do pupilloplasty in these cases. So nothing great in chopping this nucleus again is a traumatic cataract. So once you put IOL, then I try to constrict the pupil. So this is single pass 4-throw pupilloplasty, which is taught by Dr. Amar Agarwal, and it's very easy to use, and everyone should learn this. It's quite handy in many cases like traumatic mydriasis or even post angle closure glaucoma attack cases comes which have fixed dilated pupil. So you just go ahead and pass one, there's a 90 proline through one of the side, and through other side you pass this arm, and you take out this loop from this side of the iris. And once you take out this loop, you give 4 throws of this proline suture and give 4 throws, and then you just pull both the ends and your job is done. It's very simple. Yes. So just pass 4 throws and you tie a knot there. And depending on the iris defect, you can go ahead and do 2-3 times. And again, I'm passing one more round there. So in the end, you have a pupillary iris defect which is closed nicely. So I think with this, I'll end my presentation. Thank you so much for giving this opportunity.
Thank you, Dr. Harshul, for showcasing very challenging scenarios and giving them very optimal outcomes.